and Hertfordshire and West Essex integrated care system with the lovely Amanda McAvoy, who's helped us to arrange it. If everyone's happy, what we normally do is we record the event, but we will stop recording when at the end, when everyone has an opportunity to ask questions, if that's okay. So recording has started. Menopause Support Group, we have a Twitter page, which is at Menopause, capital M, capital P, 1. So do follow us if you'd like to. We do post lots of resource and lots of interesting things. If I may introduce my glamorous colleague, Ellie Stewart. Ellie is the clever one. Ellie's clinical. Ellie is a senior matron for gynecology services and a urogynae nurse. And I'm not clinical at all. I'm strategic lead for health, wellbeing and retention for Suffolk and North East Essex integrated care system. Ellie's got a fabulous presentation to go through. And then, as I say, you'll have an opportunity to ask any questions you'd like to ask us at the end. Just to say that we do have another event on the 14th, correct me if I'm wrong, Amanda, in the afternoon, I think. During the day, certainly, which is an event to train managers, and we're going to talk about how you can support your staff with menopause, how the organisation can, how you can as a manager, and also we're going to talk about inclusivity with menopause as well. So do sign up for that one. Over to you, Ellie.
Nice to see everybody. Well, not everyone's faces, but everyone's initials. As Debs has said, my name's Ellie. I am a matron at the West Suffolk Hospital, and I'm a specialist nurse in urogynecology. So I'm just going to share my screen now, hopefully. Sorry. I think my computer's a bit slow. I've had a bit of a mare of a day today. Can you, Debs, can you still hear me?
I can.
Can you see that yet?
I can't see that yet. I'm happy to share it for you if you'd like me to.
Yeah, you can do, because it looks like mine isn't working today. Sorry, everybody.
No problem at all. Can you see that? Can you see it?
Yes, I can see it.
I can't. Hold on. Oh, geez. Yes, I can see that now. Thank you.
Okay. Tell me when you want me to move the slide on. No problem at all.
So sorry about the slow start, everybody. So as I said, I'm a specialist nurse in urogynecology with quite an interest in the menopause, because a lot of the women that I see for urogynae problems, and urogynae problems, I mean, I see women with symptoms of prolapse, incontinence, some sexual issues, and a lot of that also links in quite nicely with the menopause. So I'm a nurse prescriber as well, so I also prescribe various things, and that's all linked in quite nicely with the menopause and talking a bit more openly about menopause. And I'm also gynae matron, so I'm very much a loud voice, singing the importance of people learning more about their own bodies and of raising awareness of any sort of gynecological issue. And obviously menopause is a hot topic at the moment, following the Davina programme on the telly. Luckily, or as a result, more people are starting to talk about the menopause, and they're not so willing to just shut up and put up, which is probably how generations before have dealt with it. So this talk today is very basic. It doesn't go into lots of detail, but hopefully what it'll do is it'll just provide a bit of a resume about the main symptoms that you can get, and the main treatments that you can try, whether that be HRT or whether that be other things that you can try over the counter, or simple remedies that you can use at home to try and improve your symptoms. So if you can move on, Deb. So what is the menopause? So the average age of a woman going through the menopause or entering the menopause is 51 years. This is the end of your natural reproductive years. And we term somebody as being menopausal or postmenopausal when they haven't had a period for more than a year. So there are a number of different sorts of menopause that you can get. One is the natural menopause, which happens naturally. You then get the surgical menopause, where women have their ovaries removed. So they might come in for a hysterectomy and have their ovaries removed at the same time, or they might have cancer of the ovary or something. So when their ovaries are removed, they immediately go into a menopause because their bodies aren't producing estrogen anymore. Some women go through what we call the induced menopause, which is where injections or nasal sprays are given to suppress hormones which make the periods stop. So that can be induced. And then we also, some women unfortunately can suffer with an early menopause, and that's also known as premature ovarian insufficiency. So this is experienced by 1% of women who are under 40 and 0.1% of women who are under 30. So it can be experienced by women of in their early years when they don't expect to go through the menopause. So the perimenopause is what's termed as the period in the lead up to the menopause, and that tends to be when most of the symptoms that you get around the menopause are experienced. Next slide, please. So I wanted to talk a little bit about the hormones that are involved in the menopause. So you've got the hormone called estrogen. So this estrogen is produced in the ovaries, which enables the release of the eggs each month, which then, if they are fertilized, implant in the lining of the womb and enable a baby to be made or develop. This level, the level of estrogen, drops during the perimenopause as the ovaries don't work as well. And again drops more after the menopause, so when you've been without a period for over a year. And a reduction in estrogen means that you might experience hot flushes, night sweats and anxiety. So progesterone, what progesterone does is it protects the lining of the womb for when the fertilized egg implants. So the progesterone levels rise around the time that the egg is released, and then this level drops when the egg isn't implanted. And what you find is that as your progesterone levels reduce, you notice mood swings, depression, anxiety, headaches and migraines as just some of the problems that you might experience. There's also a change in the testosterone levels. Now, testosterone isn't just a male hormone, it's produced by women as well, and it protects your bones and your muscles. And in our 20s and 30s, it gives us a lot of extra energy and it helps to stabilise our mood. So as this drops during the perimenopausal stage, we might be experiencing some fatigue, moodiness and irritability, loss of muscle strength and difficulty in concentration and memory. So you can see there, they're the three main hormones that are involved and how they affect us and our symptoms or our condition, our symptoms as they all drop around the time of the menopause. Next slide, please. So there are 34 menopausal symptoms. I think we probably all know of 3 or 4, but the more I've looked into it and the more I've read about it and the more I've seen on social media and various websites, the more I realised how many symptoms there are. And 3 out of 4 women can experience symptoms, with 1 in 4 suffering with serious symptoms. And the main symptoms that menopausal people attend their GP for are anxiety and sleep issues. So they can be categorised into 4 main categories. 1 is vasomotor, 2 is psychological, 3 urinary and vaginal, and 4 they just go into an others group. Next slide, please. So the most common vasomotor symptoms that you might get around the time of the menopause, and you might be able to tick off all of these, some of you, or some of them in every single category, or some of you may not be getting any. So the most common vasomotor symptoms are hot flushes, night sweats. People notice that they increase in the amount of sweating that happens. Their pulse increases. They feel faint or weak. They feel fatigued and fatigue much easily. They don't feel they've got much energy. Some women feel nauseated and some suffer with insomnia. The psychological symptoms that you might experience are nervousness, anxiety, irritability, You might feel a little bit angry or depressed and find it difficult to concentrate and feel as though you don't really, you have quite a low self-esteem. You may notice what we term as brain fog, which is where you have a deterioration in your memory, or you can't quite grab the word and your brain just feels foggy the whole time. And some women suffer with a decrease in libido. So from a urinary and vaginal point of view, some women notice that they get vaginal infections, some women notice urinary infections, and that's usually due to a lack of estrogen or a reduction of estrogen in the tissues around the vagina, because vaginal tissues are kept in good condition by the estrogen, so when those levels drop, you can have significant vaginal issues and vaginal symptoms, and that's one of the things that I can talk about till the end of the session. But obviously, I'll move on to other things. But other things could be painful sex. Some people can suffer with incontinence, both when they leak, when they cough and sneeze, and when they have to rush to the toilet and they don't quite make it in time. Some women notice bleeding after sex, and also again a decreased libido. And some other fantastic symptoms that we all potentially have to look forward to are where your skin feels like it itches or crawls, you get joint pains, weight gain, headaches, tiredness, increase in risk of heart disease and lower bone density. So you can see the menopause is full of lots of different symptoms, and so you might not appreciate that you are going through the menopause, and you might be thinking, oh, actually I've got some of that and I've got one of those, and maybe that might be contributed, and maybe I actually am perimenopausal, but I don't have the hot flushes. So it doesn't mean that you have to have hot flushes to be going through the menopause. I think that and the insomnia, as I said earlier, are quite common symptoms, but a lot of these women can also experience as well. Next slide, please. So what about diagnosing the menopause? So NICE, which is the National Institute of Clinical Excellence, have got guidance on this, and they're very clear about this. And that as GPs, we should be going on, or healthcare professionals, we should be going on symptoms. So if you're under 45, you can do an FSH level, which is called a follicle stimulating hormone level, approximately 6 weeks apart. But if you're over 45, this isn't indicated, because sometimes you'll do these tests and these tests will come back normal. And then your GP will think, well, she's not perimenopausal, and not treat you with HRT or give you any advice when actually you are. But at that point in your cycle, everything was normal. So it's important that you don't go by blood tests anymore, and that you perhaps keep a diary. So there's a fantastic app called Balance app, which is written by a GP, and it's a really good way of documenting all of your symptoms, which then provides a symptom profile to enable you to take to your GP and say, I'm not depressed, I've got all of these symptoms, and I think I'm actually going through the menopause, so that they can hopefully help you come to a diagnosis or come to some sort of help me with a treatment regime. So I wanted to mention a bit about contraception, because it's really important that you don't assume that you can't become pregnant during the perimenopause, so you still can become pregnant. So if your last period was before 50, it's suggested that you should use contraception for 2 years. And if your last period was over the age of 50, that you should use it for another year. Next slide, please. So there's lots of little simple things that you can do to try and help improve your symptoms, as well as tracking them on the Balance app. There are simple things that you can do that might mean that you don't need to go and see the GP yet, or that you don't need to consider HRT. So things like stopping smoking. So smoking can make your hot flushes and your symptoms worse, and it can actually make the menopause come earlier. And we also know that unfortunately smoking is bad for your health in general, as it can give you cancer and lots of other problems. It's important, if you can, to get out and do some exercise, because we know when we've been for a nice walk, or we've been to the gym or done a class or done something where we've been outside and we've been exercising, it produces endorphins, which helps to keep our mental health in good nick. So not only that, it helps to keep our body in good condition as well. So exercise is really important. So even if you don't fancy it, pop out for a walk, and you may find that helps just with your mood in general. So keep an eye on what you're eating, because some things that you drink or you eat might trigger some of your symptoms. For example, we were talking earlier about Debs's mulled wine. We know that alcohol can increase symptoms, and that it's not particularly good for your heart, for your bones, and for sleep. So that might be something that if you're drinking a lot of red wine, you reduce the amount of red wine that you're drinking or alcohol that you're drinking, and you notice that some of your symptoms of your hot flushes and stuff go away. And it's the same with caffeine, because these may trigger symptoms and also affect your sleep. So you can try and control your heat or your hot flushes by using a spritz, which is sort of like a spray thing over your face or over your body. There's something which is called a chillo, which is a pillow, but it's quite a cold pillow. Bamboo is another material that's been used at the moment for sheets and things, which can be a little bit more cooling, and then obviously also fans. Women often look to CBT, which is cognitive behavioural therapy, as a way of managing their stress, because we know that when we're stressed, we're more uptight. That makes us more anxious. It causes problems with the fight or flight hormones, which can then exacerbate symptoms of the menopause. When it comes to bed, and if you're not sleeping particularly well, put on that onesie that Ellie has, and think about a routine that you can use every night. So try and go to bed at the same time. Don't watch telly in bed. Don't use your phone in bed. Try and spend the time just before going to sleep, relaxing and doing something that's calming instead of doing something that's going to stimulate you, which then may mean that you don't sleep. Perhaps you could consider vitamins and calcium. And you can get things like that over the counter, which I'll talk about in a bit. But you do need to be very aware of false claims. So I don't know if any of you have heard of the magnet, which you put in your knickers, and it's supposed to help with your menopause. Obviously, that there's no proven research to say that it does. So you have to be very careful what you buy, because people will sell you a lot of our guff over the counter, but it doesn't necessarily work. And what we do suggest is if you're going to try a herb or something like that, that you use one product and that you use it for 3 months to enable your body to get used to that. If you're using 3 or 4 all at the time, you may find that you don't know which one is actually working, or that none of them are working. So it's worth just buying one, trying one for 3 months and seeing if that improves your symptoms. Next slide, please. So then we move on to HRT. So you've tried some of the simple things and they aren't working. So there's lots of different things to know about HRT. Estrogen and progesterone is what you would be prescribed if you have a womb, because obviously we need progesterone to protect the lining of the womb, because if you're giving estrogen, estrogen stimulates and can cause the lining of the womb to become thicker, which can then cause problems with abnormal bleeding and potential cancer. So it's worth it. You need to take estrogen and progesterone if you have a womb. So for those women without a womb, they will need estrogen on its own. And there's lots of different ways of prescribing and giving HRT. The first is cyclical. So what that means is in the perimenopause, when you're still having periods, or continuous HRT, which is when you're postmenopausal and you don't have had or haven't had any periods for over a year, or when you're over 54 years. You can take this in the form of a tablet, or transdermally, and this seems to be the way that people tend to be giving it at the moment. So if you use a patch which goes on you, or you can use a gel which you put on the inside of your arm, or a spray, that goes straight into your body. If you're taking a tablet, it goes through your liver, so putting it on your skin or transdermally avoids the first pass. So actually you can find that you get less of the side effects when you take it that way. Vaginally, so you can use a cream or a tablet inside the vagina to re-estrogenize the tissues to help reduce urinary tract infections, make sex more comfortable, and help just stop your vagina just feeling uncomfortable. So what we suggest is that you start with a low dose and work up, and again it can take 3 months before you notice any difference. So the benefits of HRT is that they can relieve hot flushes, night sweats, mood swings, vaginal dryness, can often improve or reduce sex drive. They also improve bone density and reduce cardiovascular disease. And this happens usually when you started the HRT before the age of 60. Next slide, please. So the side effects, unfortunately, there's side effects with everything. And we know that when we're producing estrogen naturally, we get some side effects such as breast tenderness before our periods, bloating, headaches, things like that. Progesterone tends to give breast tenderness, headaches, fluid retention, might make us feel a bit clumsy, give us a few spots and make us feel a bit depressed. But these usually pass within a few weeks of starting the treatment. There isn't any evidence that HRT causes weight gain, as this often happens naturally anyway around the time of the menopause. One of the potential side effects is breast cancer, and there is a slight risk of clots and stroke when you take oral HRT. So you can also be given testosterone. So this is given if your ovaries have been removed or if you've got issues with the low sex drive and you need to speak to your GP about that. And again, that's a good time to fill in the Balance app with all the symptoms that you're getting. There's also a medication called Tibolone, which is similar to taking combined HRT, so similar to taking estrogen and progesterone. This can relieve hot flushes, low mood, reduce sex drive, but it's only suitable for women who had their last period over a year ago. Next slide, please. So what are the benefits in HRT? So a reduction in estrogen levels increases the risk of a heart attack, cardiovascular disease, stroke, osteoporosis, and increases cognitive decline and Alzheimer's. So using HRT or using estrogen reduces the risk of developing these symptoms and conditions. So the benefits is that it can relieve hot flushes, night sweats, mood swings, etc. It improves your bone density, and it also reduces your cardiovascular disease, again, as I said, when you start it before 60 years old. Next slide, please. Now, when I prescribe, or when people, I think in the 70s or 80s, maybe 80s or 90s, I can't remember which decade, but when I was a kid, when I was a kid, I remember there being a lot of information in the newspapers about HRT and how bad it was for you and how it gave you breast cancer. Now, this is quite a small, busy slide, but if you can get hold of this, it's a really good one to show your patients if you're talking to them about breast cancer and HRT risk, but it's also quite a useful one to show you the risk in comparison to other things. So the top line says 23 cases of breast cancer diagnosed in the general population. So there are an additional 4 cases in women on combined hormone replacement therapy, so HRT. There are 4 fewer cases in women on estrogen-only HRT. So if you only take estrogen, your risk reduces. There are additional 4 cases in women on combined hormonal contraceptive pill, and an additional 5 cases for women who drink 2 or more units of alcohol per day. So it's actually a larger risk to drink 2 or more units of alcohol than it is to take a combined HRT. There are additional cases in women who are smokers, and then an additional 24 cases in women who are overweight or obese. So you can see that HRT has its risk, and actually it reduces the risk in women who take estrogen only HRT, but the risk of being overweight or obese significantly increases your risk of breast cancer. And then the last line there just shows that there are 7 few cases of women with HRT who are taking at least 2.5 hours of moderate exercise per week. So actually exercising can reduce the likelihood that you get breast cancer. I just think that's a really good thing, which I think for me, when I thought about it, really brought it into proportion. So it's important to do your exercise because it reduces the likelihood, and actually estrogen only HRT reduces the likelihood, and there are 4 extra for women on combined hormonal therapy. But if you're overweight, there's 24 extra cases. So you can see that HRT, I think when you weigh up the benefits that you can notice against the risk, I think that's quite a good infographic to demonstrate that. Next one, please. So what alternatives are there? So we have to appreciate that everybody reacts very differently to different herbs and things. So you need to think about not one sort of herb fits everybody. NICE looked at all herbs that were available. It's really important that you check that there's a traditional herb logo on it, which is means that it's been looked at in detail to make sure that it actually does make a difference or can make a difference to symptoms. So some of the ones that are on the traditional herb register are red clover. So red clover can help with hot flushes. Black cohosh, they both can help with hot flushes. There's something called St. John's wort, which can help with mood. and it also may reduce your hot flushes, but you have to be careful that these may interact with some of the other medications that you're taking. So it's worth asking your pharmacist before you take anything herbal if you're taking other medications. We can then look at complementary therapy such as acupuncture. There is limited evidence as to whether that's beneficial, but some people do notice an improvement, and sometimes it's a placebo effect, and who cares if it is, if it's making your symptoms better. Yoga, CBT and Pilates can also help. Bioidentical hormones have been quite trendy recently. They are made from plant sources, but they're not recommended. We wouldn't recommend them as they're not regulated, and there's no good evidence to show that they help, and to show how effective they are. There's also something, someone's mentioned in reflexology. Yes, that can help as well. Sorry, I'll add that to my slide. Clonidine can help reduce hot flushes with very little effect on hormonal symptoms, and antidepressants. So what I tend to hear is that people go to the GP with some of these symptoms and they get automatically bunged on antidepressants. So if you don't think you're depressed, if you think some of these symptoms are as a result of the menopause, then just mention that to the GP. So there are alternatives that you can try, as well as the simple things like reducing caffeine and stuff before you want to consider HRT. Or some women are just like, yeah, just give me HRT. I'm not here to say one or the other. I'm here just to show you the different things that are available. Next slide, please. So what can you do? What I would suggest you did is keep a diary of your symptoms. So whether it's a written diary or whether it's on the app, and try the simple things that I've suggested, and then go and see your GP. So there are some absolutely fantastic resources which I've just put down here, which are available. And now we're on Twitter or we're on Instagram and Facebook. We're talking about things more. There's much more information readily available. I follow, for example, the Menopause Doctor. She's fantastic. She puts very simple posts up explaining lots of different conditions within the menopause and how to make things better. One of my colleagues is called Catherine, and she does the Flux State, which is, again, a fantastic resource where she chats through, she does coaching, and she also chats through some of the symptoms and things that you can do, and has catch-up coffees and things like that online so that you can talk to other people. There's something called Peppy Health, which if you log on there, you can if you log on to that, then they can provide individualized support. So that's a support group on the phone where you phone and speak to a nurse and ask for their advice. I've tried this, I've tried this, I've tried this, and then they can make other suggestions and help build a plan so that you can then go to your GP a little bit more aware. There's obviously some good books, and for women who have noticed that they've got premature ovarian insufficiency, which is the early menopause, there's something called the DAISY network, which is an absolutely fantastic resource. So they're all really, really good resources, and there's lots of information around. And I know Deb's regularly puts stuff up on her Twitter page for things to keep an eye out for with regards to more information. So that's my talk done today. Please bear in mind, I'm not an expert on the menopause. I know the basic stuff. I won't be able to answer any questions about anyone's HRT because I'm not a prescriber of HRT and I don't know it as well as somebody who works with it every day. But if there are general questions, I might be able to help answer. But over to you, Debs.
Thanks, Ellie. Thanks for doing your fantastic presentation, as always. We have run a series of these in MyPause on lots of different subjects. So just to reiterate what Ellie said, Ellie may be clinical, but Ellie doesn't know your individual clinical pictures. So Ellie can't give you clinical advice. But if anyone has any questions at all about menopause as a sort of overview, please do ask us. KJ, you have a question. I'm sorry, that's showing you as KJ. Sorry.
That's okay. Just I don't know whether you'll be able to give me any advice, Ellie, but with regards to knowing when menopause started. So I've had the Mirena in for 10 years and wonderfully not had a period for 10 years because of the Mirena. So I know when my symptoms started, but it's hard to know because the doctor keeps saying to me, you know, what's your menopause? Sorry, what's your menstrual cycle? And I can't answer that question. So
yeah, you won't be able to. I think you need to go when your symptoms started because you will never know because of your you never know, because the hormones from your Mirena will have stopped your periods, but you need to go by the other symptoms. So when you started to get hot flushes or all that sort of stuff, that's when I would imagine that you would have started going through the perimenopause.
Right. Okay. So if the realization dawned on me sort of towards the end of last year, so about a year ago, that's when those symptoms, when you suddenly realize you're getting all those symptoms, you go, oh, hello. That's when and then I started HRT in June. So is that, am I doing the right thing? Am I peaking too soon?
No, I don't think so. I think